He knows him, doesn't require. He is a professor and HOD at ASI Medical College. He has more than 160 publications. He has delivered Brigadier P.N. Bhatt, V.A. Punos, and Panindranath Tota, Vijayalakshmi Kamath orations. He was president and chairperson of our education cell in IACTA. He is editorial board in IJE, JOACP, ACA, and BMC. He is examiner for MD, DM, NBE, and he is also a faculty selection panel member at AIMS, PGI, and EMANS. Sir, I would like to...
Talks would be a little difficult, but I'll make an attempt to do that. Thank you, Chairperson, for that introduction. I thank the organizers for having me here today. And we'll just talk about perioperative management of patients with implantable electronic devices. This is a cardiac setting, so I will not talk about deep brain stimulation or chronic pain, where also you have implantable devices. So why is it important for us? It is important because we are seeing a lot of patients with myocardial ischemia, cardiac problems. So there will be lots more patients coming with these implanted devices. The AHA recommends that anybody with less than 40% EF should have an implantable devices. That might not happen in India. So if you look at the demography, 40 to 50,000 implants every year. You have at least 30,000 of these for bradydysrhythmias, say atrial or nodal dysfunctions, about 5,000 for tachydysrhythmias, which are life-threatening, and the rest for cardiac failure patients. So what we call cardiac resynchronization therapy. So it's nice to know why it is important when you tackle a patient with non-cardiac surgery. So one is that you have to know the pathophysiology of the common problem, or the patient coming with his own problem and his associated comorbidities, renal dysfunction, cardiac, or other problems like diabetes. You also have to know about the device itself and any factors that can interfere with the working of this device. So everything is essential to know about a cardiac implanted device. So this device essentially comprises of a pulse generator. It is a small, like a battery, which is giving off some impulses. So, and this has to be carried to the heart, so you require a couple of pacing leads. So these can be either unipolar or bipolar. The unipolar being there is just one electrode which acts as the cathode, and the box itself acts as the anode. Bipolar means they are both very close to each other, so the loop is very small between the two, and that reduces their susceptibility to interference. Epicardial leads are generally kept right on the surface of the heart in open heart surgeries and pediatric patients. So coming to the device, it can be pacing one chamber or two chambers. So a single chamber in the right atrium, dual chamber, right atrium ventricle, biventricular, like I said, for heart failure. So both ventricles are paced together. So you have leads in RA, RV, and something in the coronary sinus to stimulate the left ventricle. And you have the automated implantable cardioverter defibrillators. This is important because they have extra. They have a sensing electrode and shocks, something to deliver the shock or defibrillate. This is some classification that you need to know. There are some positions for each of these devices. So they are listed as first, second, third, fourth, and fifth. The first position denotes the chamber that is paced. Second is what is sensed. Third is response to sensing. Fourth is whether it is programmable. And fifth is multi-site pacing. So all of them have some denominations like 0, none, A, V, and D, atrium, ventricle, and dual. This is for chamber paced, sensed, and for multi-site. Whereas if you have response to sensing, it can be either inhibited, triggered, or dual mode. And for programmability, whether it is rate modulated. So these are some classifications you should understand about the other functions that the pacemakers have. So automated defibrillators, they sense the VT or the VF and then react. So what does it do? How does it do? It is called the probability density function. So if you have a baseline like ST segment, we say ST depression elevation. When you monitor ST trending, the elevation or the change from the baseline it detects, and it can either respond to rate or the PDF. It takes about, these are the timings it takes and the amount of energy it delivers. So generally it delivers about 750 volts, that is about nearly 30 joules. So it also has some built-in features like anti-tachycardia function. So what it does is it overdrive pacing. It goes at a very high rate to capture the rhythm. Or if there is a shock, and then after the shock, if the patient has a bradyarrhythmia, then it also has a bradydysrhythmia or bradycardia capability. So these are all important built-in safety features in the mechanisms. Again, for AICDs, you have a classification based on the shock chamber, the anti-tachycardia pacing chambers, the tachycardia deletion, and the bradycardia pacing. So the same like we had for the other ones applicable, including the tachycardia detection is either electrogram or hemodynamics. And if this ICD code is present, it indicates that the patient has a cardiac pacemaker. What is worrying us in the intraoperative period? It is the electromagnetic interference which is causing disturbance with the function of the pacemaker. Generally, radio frequency waves are 0 to 10 to the power of 9 hertz, and microwaves are 10 to the power of 9 to 11. Only higher frequencies as X-rays, gamma rays, and others do not interfere with the function of the electromagnetic or the AD. So for us, in the source in the OT is cautery or similar equipment. Depends on whether they use monopolar or bipolar. Monopolar current is perceived as an aberrant cardiac impulse that it can trigger off the function or inhibit or trigger off the function. Whereas bipolar, like I said, has a smaller antenna loop because they are close to each other, and the devices are better off with a bipolar, and most devices have a titanium casing to stop this from happening. So I don't know, a lot of slide is missing. Anyway, the problem again is it can be either undersensing or oversensing. So the undersensing is basically failure to detect any intrinsic activity, whereas oversensing, so if it is undersensing, what happens is that despite there being some activity, there will be this, it is not sensing. So it will either overpace or it can cause potential malignant dysrhythmias. Whereas if it is oversensing the activity, then it will be inappropriate detection and it might not actually pace or when it is required to pace. Hospital sources, like I said, is either cautery or diathermy. Electrocautery is radio frequency. Shortwave diathermy is directly applied to the skin. So when you come to preoperative evaluation, what you need to know is that one is that you have to identify the pacemaker, you have to determine the pacing mode, and you have to have an idea of why this pacemaker was kept and when was the device implanted, when was it last checked, the anatomical position of the active generator, battery status, and whether the patient is pacemaker dependent. Amongst the important investigations, an ECG and chest X-ray will give you a lot of information. So the ECG, if you take a 12-lead ECG, it gives you whether the function is appropriate, whether the polarity of pacing is done, and what is the baseline of the patient's heart rate. So if you see this, the dark arrows indicate the atrial pacing. It is followed by a normal QRS complex. So atrial pacing is generally followed by a normal QRS complex. So if you have a ventricular pacing, it is closer to the QRS and the QRS is wider. And this is telemetry from the implantable cardioverter device. You will see that at that point of dark bars, there was a shock delivered, and then 14 joule shock was delivered, and the patient recovered with a bradydysrhythmia. So a chest X-ray also tells you important information about the CIED. So this is the first one is a normal pacemaker. You just see two leads. This is two chamber. The next one shows you fractured. The arrows show where there is a fracture or discontinuity in the leads. This is basically a biventricular pacing, which is resynchronization. You have right atrium, right ventricle, and left ventricle, and you will see the box or the pulse generator is also larger than what it is for a normal pacemaker. And if you see this, there are some thick white lines. These are the shock coils. These are the AICDs, Whereas if you see the one on the right side, that is the resynchronization therapy with shock coils and one lead in the left ventricle, the one on the C near the apex or the free border. So this is how you differentiate. If you are good enough, you can read the X-rays and determine what it is. So in patients where you cannot keep, because of poor venous access, you can keep a subcutaneous one also. One you see on the chest wall, and you see one shock coil. And this is what we have now. Technology is improved. You have leadless pacemakers. Leadless pacemakers can be either single or dual chamber. What is depicted here is in the right ventricle. So you can have dual chamber also. Sometimes you see a wire sticking out, which means that it has gone through the pericardium and is outside. So what are the recommendations for the Heart Rhythm Society for determination of function? Within 6 months you have to evaluate for an AICD, within 12 months for a conventional pacemaker, within 3 to 6 months for a resynchronization therapy. And also you have to determine whether they are dependent. When more than 40% of the ECG responses or complexes are followed or associated with a pacing spike, that means they are dependent. So you have to take that as pacemaker dependent. So when do you reprogram? Reprogramming does not protect the machine or the circuitry. So what the indications are: significant pacemaker dependence, defibrillator function, or advanced functions or special patient indications. You need to reprogram them to whatever VO modes or AW modes or DWO modes. This would be nice if I could do that. So when you use a magnet, generally what happens, we say magnet should be kept available. The magnet has there is something called a reed switch. So it deactivates it and goes into an asynchronous mode. So that we will not. So the idea is that you can go into an asynchronous mode. Once you remove it, it will go back to its normal function. So coming to intraoperative care, one has to be careful that the anesthetic plan should consider the cardiac state, the comorbidities of the patient, and the surgical intervention that is planned. So avoid all the things that we have been told in the previous two things: hypoxia, hypercapnia, acidosis, electrode. All of them cause disturbance of electrical activity at the cellular level. So all of them can influence the pacemaker function and can precipitate dysrhythmias. So you have to identify the device and the response to electrocautery. With implanted defibrillator, you can keep an external defibrillator. You can use transcutaneous electrodes, which are kept in an anterior-posterior configuration, at least 10-15 centimeters away from the edge. And if you have a dysrhythmia, treat them with ALS protocols. So monitoring all the minimal mandated, an ECG which displays and demonstrates pacing spikes, and can monitor for diathermy changes. So you have a filter, or you put a filter function on that, and a pulse plethysmograph is the best way of seeing whether there is any disturbances, because ECG can show artifacts, and also invasive blood pressure monitoring can give you a beat-to-beat response. If you have a central venous access, avoid it for at least 3 months after placement of a lead, because it can cause displacement of a lead. So this is basically showing a inhibited mode: atrial chamber paced, atrial chamber sensed, and inhibition. So if you see the bottom stern, you will not see atrial spikes because they are inhibited by atrial activity. And this is UTC 2 spikes, one before the QRS and one at the top. So this is basically a dual chamber pacing. Anesthesia, does it interfere with function? Anesthetic molecules per se do not interfere with your pacemaker. If there is a prolonged QT interval syndrome, then avoid those drugs like haloperidol or ondansetron and other things. If you are using fentanyl and dexmedetomidine, be careful because it can cause bradycardia. And succinylcholine can cause fasciculations, which can cause either oversensing or resulting in pacing inhibition. Hypovolemia, what happens if a patient is hypovolemic? Those patients, reflex tachycardia will not be apparent, will not manifest. So either direct monitoring is best, or keep the fluid loading for the patient, or maintain euvolemia. If you use cautery, short bursts judiciously, 1 second interval with 10 seconds interval and 1 second cautery, and keep the return plate as far away from the pulse generator. Bipolar current is of course recommended. If you have to cardiovert and defibrillate this patient, there is inbuilt protection called a Zener's diode. It prevents the current from being transmitted to the defibrillator. So just to have because these patients can also present you for remote location anesthesia, I thought I would add a few slides on that. If you are taking these patients for magnetic resonance imaging, what happens is, because of the very high frequencies, there is a reed switch within the device closes and they can go into asynchronous pacing. So there can be inhibition of pacing and rapid pacing can take place, or patients can have severe discomfort and heating of the electrode. So there are now devices which are MR compatible. Earlier ones would say they are MR non-conditional, so they cannot be taken into the MR suite. And if you are taking them, say, for lithotripsy or extra shock or corporeal shockwave lithotripsy, then these patients would, the ideal is that radiofrequency ablation, the current path should be as far away from the pulse generator and leads. So if lithotripsy, you have to avoid focus of the beam near the pulse generator, and because or you have to disable the atrial pacing. And the lithotripsy pulses should be timed to the ECG. If these patients are coming for radiation therapy, it is considered safe, so a non-neutron beam is supposed to be used. If a neutron beam is used, you have to check the function of the pacemaker every week. And if the location for the neutron beam is near the CID, you have to relocate the CID device. If these patients come for ECT therapy, basically the EMI does not affect the pacemaker, but subsequent seizure activity can cause a trigger off because it can oversense. So you may have to resynchronize these, and if there is a defibrillator function on an ASCD, you definitely have to reprogram it. Pain clinic, patients come for transcutaneous nerve stimulation. Theoretically, they can cause pacemaker inhibition. So then that is a possibility that you must keep in mind. So once these patients are through with their cardiac or non-cardiac surgery, all these patients post-operatively high dependency unit with continuous monitoring. There should be a full telemetric checkup and reprogramming of the implanted device, and all the anti-tachycardia therapies of implantable defibrillators are reprogrammed to their original settings. Otherwise, they are still prone for malignant dysrhythmias. So patients' recommendation, patients with ICDs who have preoperative reprogramming to inactive tachytherapy should be on monitoring continuously for the entire period of inactivation, and external defibrillation equipment should be readily available, and systems should be in place to ensure that ICDs are reprogrammed to active therapy. This is a class B recommendation. So what happens if a patient dies under your care with an AICD or a ICD implantable device? You have to dispose it off. Basically because there is a risk of lithium batteries exploding. So all of them, ideally, if they are AICDs, they can be sent back to the company for interrogation, because that will tell you whether it was a device dysfunction which caused the death of the patient. So that is a normal strategy that should be done. And there are some issues, ethical issues about reuse. So some of the countries, especially Africa and other countries, there are instances where they are sent back to the manufacturer, sterilized, the equipment is made and brought back for reuse, which can save much more lives. So just to conclude, like I said, we'll be seeing many patients. I'm sure all of you have already seen some of patients with pacemaker or implantable devices. You'll see many more of these patients presenting. Most of them would be well rehabilitated, in the sense that by the time, if they have had an IICD implanted, that means they have had the best workup done and the best device or the best kind of treatment already provided, so they will be well rehabilitated. So you should understand the functioning of these devices and associated problems and form a management strategy to better manage these patients. So there would be some other non-cardiac indications for pacemaker implantation. And finally, as all of them end with a straight line, thank you very much for listening patiently.